Arita McCoy, MSN, CRNP, is a board-certified nurse practitioner at the Johns Hopkins Parkinson's Disease and Movement Disorder Center. During her 15 years at the center, she previously worked as an outreach assistant and research nurse. In her current role as a nurse practitioner, Arita provides clinical care to patients and ratings, performing procedures and clinical trials. Also in her role, she is the coordinator of the Johns Hopkins Parkinson's Foundation Center of Excellence, which allows her to play an active role in community outreach and education. She has a special clinical interest in the advanced therapeutic treatments options for individuals with movement disorders. Arita, I'm so happy to see you again. I'm so happy you're here.
Thank you so much, Eden, for having me, and thanks everybody who was able to join today. Eden is right. We have seen each other several times in the last couple of weeks here. So this talk was actually a talk that I had developed for a retreat that we had for patients and care partners and community leaders in Parkinson's disease in Bethlehem, Pennsylvania. And since then, we also did this same talk in Severn, Maryland, which is in Anne Arundel County of Maryland, about 30 minutes from Baltimore. And bringing this talk to you guys virtually today. So hopefully we're hitting a couple more states and cities and folks who may benefit from this information. So thanks again for you guys' participation today. As you know, I'm going through the talk, I love to use Zoom sometimes, and I think it's most helpful because as you have questions, you can jot them in the chat. And so then you feel like you don't have to wait until the end and raise your hand. You can get your questions out and then we will answer them at the end. Eden, remind me how much time I have.
We're good for an hour, so you have until 4 o'clock.
Okay, very good. So I will certainly end before 4. And so if you guys have questions, then we will definitely take care of them at the end of the talk today. Okay, so what our goal is with today's conversation is to discuss the best way to coordinate healthcare in Parkinson's disease. And I think, you know, as we all sort of go through the journey of Parkinson's, the questions are always, you know, how do I best care for myself? And so in this talk, I'm talking about the best ways to organize your thoughts, know what's important to report to your clinical team, but also how to prepare for these medical appointments that come up, you know, 3 to 4 times a year. That might be times that we have a lot of questions that need to get answered, but it's just best to kind of have an idea of what we're looking for on your care team and how we can best help serve your needs. Okay. So that's what we will focus our next hour on today. All right, so just to kind of set the foundation of what we're talking about, I'm sure I do not have to explain to folks on our call today what Parkinson's disease is, but just so that we kind of understand the groundwork in terms of the things that we talk about are important to track over time, I will kind of hit the high points. So we know Parkinson's is a progressive disease. It's chronic, which means we can't get rid of it. It's something that'll stick around. And it's also a complex disorder involving the nervous system chiefly, but as we know, it also involves a lot of other systems of the body. This comes from a lot of different things that we're learning about over many of the last couple of years, but the main pathological problem we're dealing with is the slow, gradual decline of these cells in the brain that produce a neurotransmitter called dopamine. And dopamine is a chemical messenger. Its role is to communicate throughout the brain and give signals that are responsible for helping us with movement. Dopamine also has other responsibilities, but the problem in Parkinson's is chiefly that it causes an issue with the way that the body moves. And dopamine is produced by the cells within a specific part of the brain called the substantia nigra. This slide kind of shows you what we're talking about in terms of brain anatomy. These two jelly bean-like structures here in the deep in the midbrain are the substantia nigra, where dopamine is produced. And we expect dopamine to then propagate from the substantia nigra through the striatum. And so this system is where we see the biggest problem. Additionally, we see problems at the level of the neuron itself. And so this is a picture of a neuron. We have billions of these in the brain. But the problem that we have is actually between one neuron and the next. So these neurons are not generating like they should, but also the dopamine, these little black triangles within the neuron are not as populous as they should be. So they're not creating as much dopamine as they should. This is the receptor of a neuron, the next neuron. So we expect for that dopamine to come off of one neuron, get into the synapse, this space in between one neuron and the next, and then that the receptors of the next neuron are able to grab on to that dopamine and allow it for smooth communication and transmission. And there are problems at multiple points in this process, okay? And so this is kind of a little blown up indication of what the issue is that we're having, that we're trying to treat, okay? Now, the next couple slides here just shows that Parkinson's certainly isn't going anywhere, okay? So we do know that, as we are all taking advantage of technology and medications that help to have us age well and age longer, live longer lives, we do see more diseases of the aging. So there was a Medicare analysis done in a paper that was published in 2007 that wanted to predict how Parkinson's disease might increase over the next decade or two. And so from 2005 to 2030, it was expected that Parkinson's disease would grow substantially all throughout the world. This slide gives a little bit more of a representation of how these numbers played out in the analysis that was done. People always ask me, well, why is it that, there's so much higher of an incidence of this happening in China? I don't have the answer to that question, but we do think that there is a bigger aging population there, and because of that, we see more diseases of the aging. So Parkinson's expected to double worldwide in this analysis of a 25-year time span. So certainly something that we need to be paying attention to. Now, when we talk about what Parkinson's looks like, we have these what are called motor symptoms. These motor symptoms are required for us to make a diagnosis of Parkinson's disease. The first motor symptom is tremor, which is a very specific type of tremor called a resting tremor that we see in Parkinson's disease, which is often unilateral. So it affects one side of the body and then may progress to involve the other side later, but chiefly starts on one side. We also have rigidity or stiffness of muscles, which we can feel on a neurologic exam. It's a different stiffness than we have if you're, say, getting up out of a chair and want to start moving, but your back is a little bit stiff or your knees are kind of moving a little bit slower than they used to. This is a specific type of rigidity in the muscles called cogwheel rigidity. Again, often present on one side more than another. It can also be present in the trunk or the main part of the body, which we feel by moving the head around a bit. And then the third motor symptom that we see is bradykinesia, which basically is a big word for slow movement. So we see that, again, in addition to those other symptoms, that individuals seem to move a little bit slower on one side versus the other. Sometimes people tell me they could tell that because when they would go to wave, they would feel that their wave was different on one side versus the other side. Other people may say that they felt like their foot was kind of dragging, wasn't really catching up with the other foot when they were walking. And so that we term as bradykinesia, or slowness of movement. We do often see that there's an impairment in gait, walking, and also balance, but this is often something that happens later in the diagnosis of Parkinson's disease, not as an initial sign. If it's happening very soon after diagnosis, we have to suspect that there may be something else at play, whether it's one of our atypical Parkinsonisms or if there's another problem that's interfering with balance. But this is typically found, but often later in the diagnosis. Now, in addition to those motor signs, we also have what are called non-motor signs of Parkinson's disease. And these are things that are less likely to be an issue in terms of movement, coordination, or mobility, but these things are relatively bothersome to people. These kind of go into 4 categories, which sometimes can have some overlap, but for the most part, we can categorize them into 4 areas. The first being dysautonomia. So that's the automatic part of the nervous system that's supposed to work without you telling your body to do certain things. So for example, if we are having problems with constipation, bowel problems, bladder problems, like the signal coming too often and people having urinary frequency or urgency, difficulty with sexual function, trouble with sweating excessively or getting too cold in certain climates, or not being able to cool down from excessive heat, low blood pressure. All of these come from dysautonomia, that automatic part of our nervous system that we can't control. We also see sleep abnormalities. Many years before people are diagnosed with Parkinson's disease, they can also have a condition called REM sleep behavioral disorder. And in REM sleep behavioral disorder, we often hear that people are talking loud in their sleep, maybe moving around a lot. Sometimes they're also having very vivid dreams, as if someone is harming them or harming their family, and they're trying to fight that person off in their dream. And that may cause them to fight the person that they're in bed with, if they're in bed with someone. Can also cause them to fall out of bed. And so these are things that happen prior to the Parkinson's diagnosis, sometimes even many, many years before Parkinson's diagnosis. But we also see, as people are diagnosed, that they can have other problems like restless leg syndrome, like difficulty with insomnia, not sleeping well. Some people have trouble with limb movement while they're sleeping, like their tremor may come back or cause other problems. So these all cause sleep abnormalities. We also see changes in mood. About 50% of people with Parkinson's have either anxiety or depression, diagnosed either before or during the time that they're diagnosed with Parkinson's. Very important for us to treat. And irritability or apathy, which is kind of this disinterest, don't really have an opinion on things, or don't really care one way or the other, right? So apathy can be a problem when we're talking about needing to do things like exercise and live the life that you need to live. If you're indifferent and kind of don't have a preference, then that can cause these mood abnormalities. Then we also see cognitive problems, slowness of thought. Not that the word isn't up there that you want to say, but it takes longer for the word to get out. So we call that word finding difficulty. Short-term memory problems. It's difficulty remembering things that are happening right now or that you need to remember soon after a conversation. Some people have executive dysfunction, where they have trouble planning things that are complicated. Again, not that they can't do it, but that it does take a lot longer to organize these things, and they may need assistance from care partners or family. So these non-motor signs can be the things that tend to really bother people more than those motor signs over time, right? Because these are the things that may affect quality of life. They may also pop up during different times throughout the trajectory of Parkinson's disease. So you may not have these symptoms when you're initially diagnosed, but they may pop up later depending on disease progression. But it's really important to know and understand that Parkinson's disease is highly individualized, okay? If you have seen one person with Parkinson's, you have seen one person with Parkinson's. Even in family lines, even in siblings, even in husbands and wives, we treat all of those types of Parkinson's patients in our practice, and we have not seen two people with the same disease presentation. Very important to realize. One of our patients discusses says that he describes Parkinson's disease as a disease that's like a salad bar. And so if we all go to a salad bar to have lunch, all of our salads are going to look different. Even if we put the same ingredients in our salad, we may have a little bit less of one ingredient and a little bit more of another. And that is completely true of how Parkinson's and these non-motor signs show up. And so again, everyone does not get these same symptoms, but they can pop up, and it's important that we know if they're going on so that we can address them. Okay, now this is a pretty busy slide that lists most of the medications that we use to treat Parkinson's disease and the classes that we have at our fingertips to treat PD. So the goal of this slide is just for you to see that there are so many medicines we have that help with both motor and non-motor function. So we got to know what's going on with you so we know what medicine to use, what medicine to try. If you've been on a medicine for many years, it could be causing side effects. So we need to carefully weigh that, and especially, when you're first diagnosed, you may be on a medicine that works really well, but as we age and the brain changes, that medicine may not be the best for you anymore. And so it's really, really important that you know that there are a lot of options out there, but it's also important for us to keep having conversations about how you're doing, because we may need to make changes with all of these medicines that we have at our fingertips. All right, now my next slide talks about how the healthcare needs can change over time in Parkinson's disease. And so very early in the disease, we're mostly focused on making sure people know as much as they need to know about Parkinson's. They're having symptoms, and that's how we've been able to diagnose them, but those symptoms are usually relatively mild and easy to control. But we also are focused on keeping you doing well for as long as possible. So we're talking about these proactive therapies that we know are extremely important, like exercise, like making sure that you're engaged socially, like making sure that you're doing everything that you want to do and living the life you want to live, and making sure that the medicines support you in that process. In mid-stage Parkinson's disease, we're a little bit more focused on controlling symptoms. And how I discuss mid-stage Parkinson's, people seem to understand when I say that when they were first diagnosed, they could take their medication when they first wake up and then go about their day. They may miss their second or third dose of medicine and not even realize that they missed it, and go on about their lives. But then at some point, the timing becomes more important. The medicine wears off and you don't quite feel as great once that happens. And wait a minute, I think I need to make sure I'm more deliberate about what time I'm taking my medicine and the amount that I'm taking, and if the amount that I'm taking is even effective. So we're more focused on controlling those symptoms. We also deal with this concept called motor fluctuations. And this picture here, this second picture on this slide that shows this graph, is a representation of how we see motor fluctuations in Parkinson's disease. The bottom of the window is what we call off time, the darker blue area. And in that off time, people often feel stiff They feel slow. They may have more tremor than they may have had before. This feeling is sort of the feeling that people have before they started taking medicine for their symptoms, or if they're late for their dose. Now we have this white area, which is where we have on time, which is where we want everybody to be, staying within their therapeutic window and doing the best that they can. At the top of the window, we have this light blue area that's called the dyskinesia area. And this is where the medicine that we're using, the levodopa, as it climbs up to the top of this efficacy, it can cause excessive movement. So we want the medicine to help you move, but if it's working at its peak, you might move too much. And so if you've ever seen Michael J. Fox in interviews, sometimes it seems like he's having trouble sitting still. He's just kind of moving around a bit. And that is what we call dyskinesia. It is coming from the Parkinson's medication, from the medicine we use to treat Parkinson's disease, but we do have treatments for dyskinesia that can help to keep it at bay. And so, we try to keep everyone within this white window. That is our goal. But as Parkinson's progresses over many years of time, this window gets more and more narrow. So you hit the bottoms and the tops a little bit more than you did early in the disease. So we have to talk with you. We have to know how you're feeling, how you feel at certain times of the day, how you feel in terms of when you last took your medicine, and what side effects and problems are you having, because that is going to influence whether or not we make changes to your medication. Now, in later and more advanced stages of Parkinson's disease, we see some progression of these non-motor symptoms. So people may be having more trouble with thinking and memory. They may be having what we call psychosis, which can mean that you may see things that aren't there or think things that may not be true. This comes from the disease itself, but also from the medications that we use to treat Parkinson's disease. Can be a bigger problem in terms of medicine interactions, or if there's an infection or another problem that's going on. So again, we have to know what's going on so we know whether it's something we expect or whether it's something that we need to be looking out for, because it might mean that there's something else going on. And again, we see that more people who are in advanced Parkinson's disease may need more help. So they may need assistance from Carepartners, family and friends. They may be considering living in a different situation with care to make sure that they're getting all of the things that they need. Again, we're also dealing with an aging body, so we may have other factors at play other than Parkinson's disease that we need to pay attention to and may affect a person's general well-being. So all of these things are kind of how these healthcare needs change over time and why we have to keep having conversations about the best way to manage you. All right. Now, common question that we get often is, what is my Parkinson's disease and what is not my Parkinson's disease? How do I know if this is a problem I should even be talking to my neurologist or care team about? And as a rule of thumb, it's important to know that Parkinson's disease is slowly progressive. So over many years of time, we see symptoms that pop up and may incrementally get worse as time goes on. But if something is happening suddenly, like overnight or over several days, that is typically not characteristic of progression of Parkinson's disease. It can mean that there's something else going on that we need to work on. Now, commonly people can have infections like urinary tract infections, like an upper respiratory infection. I have a little bit of a cold today and I'm not feeling like myself. All of these things seem to affect the way that we move when we have Parkinson's disease. It's mainly because there's energy and effort needed by your body to focus on this other problem that needs to be dealt with right away. And all of that reserve that you're normally using to help manage the Parkinson's disease is now focused on fighting off this other problem. The same thing can also happen with medication interactions. So if you're taking a medicine that interferes with your Parkinson's treatment or maybe affecting your brain in different ways, this can cause symptoms to get worse very quickly. We also know that other medical problems can cause this to happen. For example, if someone has an issue with an orthopedic problem, so they have a really bad spinal disease and they may have impingement of their nerves, that might make them not be able to walk very suddenly. And if we know that they have existing history of a spinal problem, we have to pay attention to how that can make their movement different, and maybe if that's affecting their Parkinson's disease symptoms. So again, if things are happening quickly, that's a red flag that it's not Parkinson's. Usually those changes that we see are cognitive changes. So having conversations and they're not making sense, you're not connecting the dots the way that you have been maybe a day or a week prior when you're talking to family or friends. Having those hallucinations, seeing things that aren't there, but that's happening in a very short time period, that's a red flag for something else going on. Also, if tremor increases very suddenly out of nowhere, or if people start falling, having a lot of balance issues that are very, very dramatic and sudden, these are our usual suspects to suspect that there is something else that we need to work up. Now, talking about the important members of the team and how we intervene when there is a problem, the first person that is very important to have on the team is who we call the primary care provider. Now, this person is the hub of all of the medical issues that a patient could be dealing with. This person would be the person that is getting all of the reports from different specialists. So in addition to Parkinson's, maybe you have a history of cardiac problems, maybe you have diabetes, maybe you have a thyroid issue, maybe you have a spinal problem. You may see different specialists for different conditions. Your primary care provider should be that person who is keeping everything organized and together and knows about you as the whole person. It's really important that any records that you are getting from other medical providers or anybody who's prescribing medication or influencing your care sends their report to your primary care provider. Now, people ask all the time, listen, my primary care provider is retiring or they're going into concierge practice and I don't think that that fits me and my goals. Or, I have to move and I'm looking for another primary care provider. How do I find someone? There is a group of primary care providers that are called geriatricians. And these primary care providers specialize in people who have aging conditions, they have conditions of the aging, and also have multiple medical problems. So these are people that have a great idea and understanding of how to treat these disorders the best. They also know what medicines interfere with each other and what things we have to pay attention to when we're considering a whole person. So that is definitely something that I recommend to folks if they're in the market for a new primary care provider. Main thing though, is that this person is someone that you can trust, someone that is accessible so that you can reach out to them if you have an urgent problem or need to talk to them right away. You also want to make sure this is someone who's close to your home. So if you see specialists, but they may be 30 minutes or an hour away, your primary care provider should be someone that's relatively close to you if possible. And also that you feel comfortable with them, that you feel like you can talk to them, you can tell them about what's going on, and they can intervene on any issues that you might have. Okay. Now, very specific to Parkinson's disease, we have the neurology team. And the neurology team are going to be your primary providers for Parkinson's treatment. These are the folks that are going to manage your Parkinson's disease over many years of time. The neurology team will often refer you out to other specialists. So again, they're also going to be quarterbacking your care from a Parkinson's standpoint. We know how important physical, occupational, speech therapy is in Parkinson's disease. They're often referring, you to these providers. Also psychiatry, if we're dealing with mood issues and we want to make sure we're managing those well. We also have urologists, GI doctors, sleep specialists, all of these people who may help to manage symptoms of Parkinson's disease very well, and also make sure that there's nothing else contributing to problems outside of what we expect in PD. Again, the neurology team should also be advised of all of the medicines that you're taking for the reasons that we've already discussed. Now, there is a specific neurologist or neurology specialist who is well-versed in treating and managing the symptoms of Parkinson's disease. And this specific type of neurologist is called a movement disorder specialist. These folks are, can be your primary neurology team, but may be a consultant that you see once a year. So if your neurologist is close to your home, but you want to see a Parkinson's expert, then that person you may see annually, or maybe even less frequent than that. This could be a neurologist, it could be a nurse practitioner, a physician assistant, but someone who works within a group and specializes in Parkinson's disease. Very important. But again, the most important thing with this, just like the primary care provider, is that you're seeing someone that's competent, that knows what you're talking about when you're asking a question about your Parkinson's disease, that you can reach out to, even if you have a question. Is this my Parkinson's and is it not? Can you send that person a message? Can you call them and they'll call you back? These are things that are very important, because if we need to work on problems right away, we want to be able to make sure that we're accessing the people who are most important in answering those questions. Now, some people say, look, I really feel confident with the neurologist that I'm seeing. It's not a movement disorder specialist. It's okay to even get a second opinion on your care. If you feel like things are going fine, that's great. If you get to the point in your Parkinson's that you feel like, I just want to make sure that I have everything that I need. I want to make sure I'm on the best treatment plan for me. At any point in time, you can get a second opinion on your management or your diagnosis from a movement disorder specialist. But again, the main thing to know is that people with Parkinson's disease don't often get care by just one person. It's a team approach that seems to be the best way to manage Parkinson's disease over many years of time. It is totally normal, maybe a little bit overwhelming though, to have multiple specialists and multiple people that are helping, but it really does lead to best outcomes in Parkinson's. Okay, so I'm going to walk you through kind of what a typical neurology visit looks like, the things that we are assessing for, and the things that are important for us to know if you are coming to see us to talk about your Parkinson's. Now, the first part of our visit is what we call the history of present illness. And during this time, this is when you'll get the question, how are things going? How are you doing? How are you feeling? We're also following up on other action items that we maybe were dealing with at the last appointment. So if we know that you've been having a problem with your balance, for example, and we sent you to physical therapy, we're asking, how did physical therapy go? How are you doing? How's your balance? Are you having falls? We're also trying to discuss new problems and concerns. So it's really important to know that this is the best time to get your questions and concerns on the table. I recommend that people in the car on the way to the appointment, as they're talking to their spouse or their care partner, or right before they come to see us, if they're coming by themselves, to jot down what are the things that are bothering you the most? What are the things that are limiting your life? And what are the things that you would want to work on? And this is when we really want to know those things so we can make sure we're addressing any questions that you have. The next thing that we're going to do is start asking you questions. So we're going to do what's called a review of systems. And we're typically asking, even if you didn't complain about it, how is your thinking and memory? How is your mood? What's going on with sleep? Are you swallowing well? Any trouble with your speech? You're having constipation, any urinary problems? We're going to ask you these questions even if you don't come to us saying that you're having these issues, because we want to know if there's anything that we need to be working on to be proactive with your care. After that, we're going to do the neurologic exam. So we're going to examine you and see what things that we might think are important to pick up. And then we'll talk about what's next. What's the plan? What medicines do we need? What things are we changing? What other referrals are we going to get started? And when do you come back to see us? Now, just so you have an idea of what our exam typically consists of, when we're trying to evaluate your Parkinson's disease objectively, we typically do this scale called the Unified Parkinson's Disease Rating Scale, or the UPDRS for short. This is a scale that measures both motor and non-motor symptoms. It also goes through activities of daily living and some of the motor complications that can come from Parkinson's disease. Now, typically we don't do the full scale as a part of our exam. Depends on what type of visit you're coming in for, but we typically usually try to do part 3 of this scale, and that is the motor exam. Now, that allows us to see kind of if things are going well from a movement perspective, but also if we've given you new treatments, this allows us to see whether or not those new treatments were effective. How is your score looking? Is it worse than it was? Is it better than it was? Or did it stay the same? And this scale, the score is sort of like a golf score. So that means the more points you get on the scale, the more affected you might be by your Parkinson's disease. Okay. And so that's what we're using to objectively rate things. Just so that you're aware, this is also one of the major outcome measures of most clinical trials that we have for Parkinson's disease. So if we're trying to see, again, how much better people are feeling, or whether or not their disease is progressing at a rate that we would expect, or if the intervention that we're administering is effective, then we're also using this as the way that we measure how Parkinson's disease is progressing over time. Some of you may have had this scale many times before. We're asking you to tap your fingers, open and close your hand, stomp your feet, walk down the hallway. We test your balance by pulling you back quickly. All of these things are ways that we are trying to measure your motor function. We often get asked about what stage am I in Parkinson's? And, staging in Parkinson's is not very linear. So for example, in staging of other diseases like cancer, we have staging that is really important because it tells us where the cancer may be located and whether or not it's spread to different areas, how involved it might be in your body. The staging in Parkinson's disease is a little bit different because it's based on how you're moving. And so if we're giving you interventions that may help, then your score can actually go back. You may go back in staging. So it's not very linear, but it is pretty important in at least giving us an idea of where you stand. And the staging is called the Hone and Yar stage. That is the name of the staging in Parkinson's disease. There's the traditional Hone and Yar, which goes from 1 to 5. And then there's the modified Hone and Yar that also goes from 1 to 5, but there's some half steps in the earlier part of this staging. And that really kind of is more important for things like clinical research. But if people ask about staging, I do explain that this is what the staging looks like in Parkinson's disease. So as we discussed how symptoms pop up, in early Parkinson's disease in stage 1 of Hone and Yar, symptoms are pretty mild and also only seen on one side of the body. They're unilateral symptoms. In stage 2, we see symptoms on both sides of the body. So bilateral involvement of symptoms. In stage 3 of Parkinson's disease, we see bilateral symptoms, and then we also see that there may be a loss of balance in stage 3 of Parkinson's disease. People remain physically independent, but they may have some balance issues. Now, in stage 4, we see that we have all those symptoms that we've discussed, but then also that there's some pretty severe disabilities. So people are having more trouble with their motor symptoms. They may need an assistive device to help with walking, like a walker or a cane. Some people may need a person to help them move. And in stage 5, which we rarely see these days in Parkinson's disease, but is still present, people in stage 5 may not be able to move on their own at all. So they may be either bound to a wheelchair or to a bed because they need support with every movement that they have. And thankfully, because of the treatments that we have to help with Parkinson's disease, we don't typically see people reach stage 5 unless they're severely, undertreated or don't have other issues that are affecting the way that they move. Okay. Now, the last part of my talk, I'll focus on how you can make the most of your visit. Okay, so this gets broken down into 4 areas. First, being organized. Second, asking questions. Third, taking notes. And then fourth, and most important, is bringing a partner with you. Now, in terms of organization, really important from a standpoint of medications, even if we're not talking about anything else, organizing medications is really, really important. If you're able to keep your medication list in an area that's easy to access and update, that is ideal. So if you have a document on your computer that you update after you come from the doctor every time that a medication change is made, or if it's in your phone and you can make changes quickly to show what changes you've made and where your medicine list is, this is the best way to keep this list organized and also to share it with people. I also recommend that people organize pill containers. So instead of taking your pills out of the bottle each time you need to take them, having a container that you fill up for a week in advance and has multiple time slots a day can help you to know when your medications are going to run out. You can call for a refill. Sometimes that refill might take a couple of days to get done through the doctor's office. So if you know that you're kind of running low, you have an idea of when that might happen, and you can be as organized as possible with that. Also, knowing the names of your providers, very important. If for some reason you are hospitalized and your family and friends want to know, how do I get in touch with your neurologist? You will want to at least make sure that all of the names of your different specialists are in one area that's easy to locate. For people who have had advanced therapies with their Parkinson's disease, like deep brain stimulation or duopa therapy, which uses a pump to deliver medication, making sure that you bring your patient programmers, your device pumps, anything that may be involved in your Parkinson's treatment with you to visits is very important. Excuse me. Also, requesting copies of your medical records and keeping your own file can also be very important. Usually, if you want to make an appointment with a specialist, they may ask for records from your doctors. And so if you have access to something like MyChart, which is a way to communicate with healthcare providers through different health systems, you can actually see your medical records through that. But in addition to that, you want to make sure you're talking about having power of attorney, both medical and financial. It's really important for all of us to consider that, regardless of our healthcare status, to make sure that we have things in place if emergencies happen. Also, advanced directives, talking about what you would want if you're not able to make decisions for yourself, if you're not able to communicate in the time of the emergency, and who you would want to contact. Now we're living in a digital age, and a lot of people who have iPhones or other smartphones, they're asking you, as soon as you set your phone up, who is the most important person we should contact if you have an emergency? Then that way, medical providers can tap right into your phone and figure out who they should talk to if there's something going on. So that's really, really important. There's also some technology that might be helpful for this. This is an app that is called Strive PD. It's a picture of what that app looks like. And this is specifically for Parkinson's disease. This is something you can download in the App Store on your phone, but it goes in and it actually has ways that you can put your medications in the app. It can remind you that your time has come, it's due for you to take medications. You can set goals, whether they're movement goals or mobility goals or goals for just taking meds on time. All of those things are interactive in the app. And then you can also list things that you're having problems with. Some healthcare provider offices participate with Strive PD so they can see in real time how your symptoms are going and use that feedback to kind of guide your visits. So this is something that's relatively new technology, but making life a little bit easier. All right, the next thing is to ask questions. I cannot emphasize how important it is that you feel like you can ask questions to your healthcare team. Specifically, when we're talking about medication, it's important that you know who is prescribing the medicine that you're taking for a specific problem. What other things might interfere with that medicine? When are you supposed to take it? Not just 3 times a day, but what time are you supposed to take that medication? Is it 8 in the morning, 12 noon, 4 p.m., 8 p.m., or is it around the clock, right? We need to know these things so we know the best way to take advantage of the medicines that we have. And then also, is this supposed to make me feel better? Is this something that I'm supposed to be using to really see a difference in my symptoms? Or is this a medicine that I'm just taking to keep a problem from getting worse? So for example, a lot of us take medicine for cardiac conditions. And if we don't take those medicines, then we could make our heart function worse over time. Right. And so while we don't expect to see any major change in symptoms, we do want to take that medicine every day. And so it's important to know the reason for these medications and whether or not we need to continue on them. And if you really do need them, sometimes as time goes on, we learn that medicines really aren't that necessary anymore. For example, some people have been on high blood pressure medication their whole lives. And we know that Parkinson's disease itself can cause blood pressure to get lower, but also the medications that we use to treat Parkinson's disease can lower blood pressure. So if people have pretty low blood pressure, they probably don't need that blood pressure pill that they've been taking for many years anymore. But we have to keep reevaluating that over time. Okay, really important to know that some insurance plans offer what's called care management. So these are specialists who actually have an expert skill in making sure that all of the things that you're trying to deal with from a complex medical perspective are dealt with in the right way. So they can educate you on medications, they can talk with your providers about whether or not these things are necessary, monitor your medicines through the pharmacy, and then also provide nursing support for things like, monitoring blood pressure and things like that, glucose if you're diabetic. So all of these things are really important to know may exist and can be benefits that you have right with the healthcare insurance plan you have. Taking notes. We talked about why taking notes is important when we're talking about talking to your healthcare providers. But even during the visit, if you are needing to jot things down, or if there's someone that is joining you for the visit and can jot things down for you. I have some patients that actually talk into their phone to keep notes, or ask me to talk into their phone to record certain things about medications or about exercise plans. And these are ways that we can make sure that everything that we're telling you in the visit is actually going to get done once you're at home. I tell people to get a dedicated notebook, a spiral notebook or a composition notebook that is all for your medical issues. So that way, you know that if there's anything that's got to deal with a medical problem, you can grab that book. Your family can grab that book. Your friend can grab that book. And any answer that you need is probably going to be inside of there. So something that's really, really important and can help take things a long way. And then, of course, having a care partner, someone who is in the loop with your medical affairs. This does not have to be your spouse. Some spouses are in tune to medical issues, and some spouses really don't want to be involved. And so this could be someone that you trust with your medical affairs. This could be a friend. This could be a family member, someone that may have some experience in the medical field, but this is someone that is your partner in your care over the years. Someone that is going to be able to be your second set of eyes and ears, and can also make sure that, even if they're not able to come to all of your appointments with you, you're having a call with them after you go to the doctor or after something is changed, so that they just know that they are in the loop with all of your medical affairs. And typically this person might be designated your medical power of attorney for legal purposes as well. Care partners are extremely important part of managing Parkinson's disease. There are some things that we may not even see on an exam when you come to see us in the office. As a patient, you may not even realize that there are things going on. And having someone that can be what I have heard as your police officer, right? Or someone that can make sure that you know everything that you need to know about yourself, but can also report to your healthcare team if there are things going on that are concerning that you yourself may not even realize. Care partners are a huge part of the process in managing Parkinson's disease, and I can't say enough about how important it is to identify this person in your healthcare. All right, and the last thing that I'm going to talk about is when people with Parkinson's disease have to go to the hospital. And this is a very important part of care to discuss, because we find that people with Parkinson's are hospitalized about 50% more than their peers. They may be in the hospital for things that are expected, but they might often be in the hospital for things that are unexpected. But we find that this hospitalization can make their Parkinson's disease worse. During the hospitalization period, medications can be given off schedule. You may get on a different medicine than the one that you take at home because of issues and problems with what's on formulary in the hospital. You might get medicines that you're not supposed to get, and this can create big problems and prolonged hospital stay. So, I like to talk about this because it's really important to know that we can do something about this problem. There's a kit that the Parkinson's Foundation has called an Aware and Care Kit. And in this kit, there is plenty of information about what things you need to know if you are ever hospitalized and you have Parkinson's disease. It's a bag, and in that bag, there's actually enough space that you can put your medications inside so that you can take medicines with you, especially if you're going to the hospital for unexpected stay, you're in the emergency room for a long time. People always ask me, well, listen, I'm in the hospital. They're not going to let me take my medications how I would if I was home. And if that hospital does not have your medicine on formulary, then you actually can have your medication identified by a pharmacist, and then use that medication while you are in the hospital, as long as they can verify that it is the medicine that you are taking as an outpatient. They may have to call your neurologist, they may have to call your primary care provider, and they're going to have to verify that medicine, but you can have ownership over your medication schedule while you're in the hospital, as long as you advocate for yourself. So this kit is available. You can go to awareandcare.org is the website through the Parkinson's Foundation, and order a kit to get sent to your house. There's an ID bracelet and other really helpful information about contraindicated medications and other things that are really important to know if you have to go to the hospital. All right, now I said I wouldn't take the whole hour, but we only have about 5 minutes left for questions. So I'm happy to take any questions that you guys have.
I did put the Aware and Care Kit information in the chat. If people want to save their chat, they can click on the 3 dots once their chat is open to save it. We do have a few questions. A lot have to do with you and I have discussed in the past, access to care. One of the gentlemen stated that none of the local doctors are movement disorder specialists. Would you use a local doc or would you travel? And someone asked about what happens, their loved one is undiagnosed but no access to a geriatrician, and the estimated wait for a movement disorder specialist is 6 months. So we do have that limited access to care. Do you have any suggestions or?
Yeah, these are really important questions. And, I tell people all the time, even if the wait is long for a movement disorder specialist, still make the appointment. The time seems like it's very far away, but it comes up quicker than we realize sometimes. And that expert opinion is very important in at least making sure the diagnosis is accurate. So even if there's someone you might be able to see in the meantime to kind of take care of the most important issues, it is very important that you still make that appointment with the movement disorder specialist. Now, if there's not a movement disorder specialist or geriatrician that is in the area, I do recommend that you contact the group that's closest to you. The reason why is because within the same state, there is ability to do telehealth. So we don't love to do telehealth for new patient appointments because the exam is so important. It's important that we see you in person. We feel the rigidity of the muscles. We see how you're walking. And sometimes the camera is just not as good, but it can give us a lot of information, especially if we weren't going to be able to get that information otherwise. So check to see if there are telehealth options. Even if the journey is long, like we said, it may be that you're getting this expert opinion, but then we're also, maybe not using that as the primary provider, but you're using your primary care and other local neurologists that can help out in the meantime.
Question about, someone said that she learns all this great information on Zoom that she never, like her doctor never brings up during the appointment. And so she says, is there a nice way to bring this up with the doctor? Like, hey, I heard this. Could we discuss it?
Absolutely. I do think that if there are specific things that you are concerned about, you absolutely should be bringing them up at the beginning of your visit. So if the question is, why aren't you reviewing these things with me? I think that's a different question. But if there are specific things like, listen, I'm having a problem with my mood and I need to talk to you about that. That's what you need to make as the main thing that you're discussing when you first come in and sit down. If you're concerned about just not getting this level of care that might be important, this is when it's time to consider maybe doing a second opinion and seeing if getting care at a specialty center or at a different specialty center may be a better option. But just something to think about, because these are questions that we absolutely do ask at all of the visits here at our center.
Are almost out of time, so I do just want to say thank you. I encourage everyone to save their chat. If you click on the open chat, you see the 3 dots, you can save it, because Aware and Care is incredible. Really would love for everyone to have these kits. So I really encourage you to order one. And we have a tradition here at PMD Alliance, our wave of gratitude. Thank you so much, Arita, for giving us your time and sharing your knowledge with us today. We are so grateful.
Absolutely, no problem. Thank you guys so much for being here today.
Thanks.